Okay, good morning. We're going to get started. Welcome to December's, one of our December Connect sessions, the Innovations Pathway related to Implementation Science. I'm Priya Shete, an associate professor and TV researcher here in the Institute for Global Health Sciences, and I'm so pleased to welcome our speaker today, Dr. Matt Spinelli. I'll go through all of the hats that Matt wears, but special thanks for talking today about implementation science as related to HIV care, which in the context of World AIDS Day, it's a really important topic to elevate, amplify, and continue speaking about, given all the kind of discussion and potential threats to advancing, progress and hopefully eventually elimination of this disease. So I'm really excited to welcome Dr. Spinelli. He's an associate professor in the Division of HIV, Infectious Disease and Global Health at San Francisco General Hospital and UCSF. He wears a ton of hats. He's the lead for PrEP at Ward 86. He also is co-director for the Implementation Science Working Group at the CFAR. He sits with me on the executive steering committee for the PRIZE Center, which is a program in partnerships and research for implementation science and equity. He teaches in the implementation science training program and is a renowned researcher in the area of PrEP. So Matt's going to be talking to us today about PrEP, HIV, and implementation science. Thanks very much. Okay.
So great, thanks so much for the kind introduction, and really lovely to be here the day after World AIDS Day. Sort of a somber year with it not being recognized for the first time in, I think, 1988 by the federal government. Kind of astounding, and also a really hard year for our field, which was disproportionately affected by the NIH cuts. 20-something% of all HIV research, and really the dismantling of PEPFAR and really all global PrEP work stopped, unfortunately. But we move on, and I think that was sort of the tone I was going to grasp here. This is I realize now this is a year old, but it did allow me to reflect. The number of global HIV infections is still 1.3 million this year. So we really stopped making progress before the current administration, and we're way past our target of 500,000 infections, which we were supposed to reach this year. Adherence is really a key component of the HIV treatment cascade. We've gotten very good at diagnosis and getting people started on therapy, but the later parts of the cascade have really become critical, particularly in the United States. And when we speak about PrEP, we're really reaching a similar paradigm where we're getting a lot more people on PrEP, but they're not staying on PrEP. The barriers to adherence between PrEP and ART adherence are similar. I'm going to be talking about both PrEP and ART in this talk. Treatment, travel, changes to daily routine, mental health, and substance use are really key. Stigma is huge for this disease. Side effects, stockouts, and simply forgetting is actually very common as someone who has to take various medications and often forgets them. So this was a systematic review, and what it found was 41% of those who started PrEP discontinued within 6 months, and suboptimal adherence for those who stayed was more than a third. So the adherence field, I'm going to give you a mini intro to the adherence field because it's necessary to understand the interventions that I'm going to discuss using the behavior change wheel. This will be a review for some from Pam. But on the top of this table, we have self-report, which is the most subjective of adherence measurement techniques, and that's something we should still always do. Ask our patients how they're doing. It's always a good idea. It's widely available, but people tend to dramatically overstate their adherence. Patients want to please us and other people on their healthcare team. So it tends to be quite inaccurate. Pill counts and pharmacy refills. They are also inexpensive. Pharmacy refills is challenging in the US where we don't have a closed system, but they tend to not be particularly accurate. I'll show you a slide showing that. For HIV, the viral load or the HIV RNA is a surrogate marker of adherence, although it's not exactly adherence. It's very expensive and is done infrequently globally. And for PrEP, we don't have an HIV viral load, so we really have to measure the adherence directly to get at that. Pharmacologic metrics of adherence are become the gold standard, or the silver standard, I guess. But we have recent and cumulative adherence metrics. The recent adherence metrics are just measuring drug levels in the plasma or the urine. And we have two more commonly used metrics that look at long-term use or cumulative use over time, analogous to your hemoglobin A1C and diabetes. And that is hair measurement of antiretrovirals. That's because drugs get incorporated into your hair at a steady pace, and your hair grows at a 1 centimeter a month of your behavior when we measure in your hair. And then dried blood spots work for tenofovir because it concentrates intercellularly in the red blood cell, and so we can measure the metabolite in the red blood cell. Now, directly observed therapy is amazing and used most frequently in TB. It's a gold standard, but it's costly and it's difficult to roll out, at least in my area. So pharmacologic measures of adherence were really brought to the forefront by the PrEP studies. What we found is in the first large PrEP study, the PrEP study, the efficacy was 44%, which was like amazing. Everyone was really excited. But subsequently, we realized it's actually much more effective than we thought. And when we looked at people who actually took the study drug, the efficacy rose to 92%. And our efficacy estimates are actually 99% if you take PrEP 3 to 4 times a week. What really brought adherence into the forefront were 2 large trials in Africa, the FEMPREP and VOICE studies, which showed no efficacy in PrEP. It launched a whole field of trying to find biological differences in men versus women, differential pharmacology, but it turned out really this was a story of adherence. When we looked at self-reported adherence and return pill counts, they were all around 90%, but only about a quarter of them had any plasma drug detected. And really similar story we've seen with doxypep studies, not effective in women in Kenya, but effective in MSM and transgender individuals in the US, were a similar pattern. I talked a little bit about the metrics of adherence, but I'm going to be talking about a urine point of care test, which has been an important part of our intervention strategies. It is a look back of about 4 to 7 days of behavior. It's really influenced by your most recent behavior, principally, and that compares to longer term metrics of adherence, like dried blood spots in hair. And my mentor, Dr. Gandhi, is sort of really revolutionized this field of hair analysis. But there's some issues with hair. A lot of people don't want to give their hair, some are bald. It requires using liquid chromatography tandem mass spectrometry, which is a $1 million machine, as we learned when UCSF real estate destroyed one of our machines. Tenofovir mainstay. Tenofovir, we focus on tenofovir specifically because it's the mainstay of both HIV prevention and treatment. 25 million use it as part of first-line ART, tenofovir limited dolutegravir, TLD. And we really wanted a way to measure adherence at the point of care so that we could use this to drive interventions. Urine was selected because it can be collected without a trained phlebotomist. A lot of the sites where we're collecting studies, phlebotomist is not available to see patients at every visit. And most people are getting blood draws once a year in HIV ART programs. And we did directly observed therapy studies. Again, that is the gold standard, the silver standard, to determine a cutoff. After we developed this test, we wanted to understand what would the clinical implications be of using it. The IPREC study, again, the first big PrEP study, in the open label extension, urine samples were collected originally to look at kidney toxicity of PrEP. And thankfully, they were saved here at the Gladstone Institute. I actually came here personally to collect them as they were about to be destroyed when Bob Grant's lab closed. And we grabbed them and we measured urine tenofovir. We found is that there was an odds ratio of 14 for low versus high urine tenofovir, predicting a future seroconversion event. You can see those who remained HIV negative. There was a variety of adherence, but the median was quite high. Prior to seroconversion, adherence dipped. And at the visit before seroconversion, everyone was undetectable for urine tenofovir. And we've seen something similar in a real-world setting at the Magnet Clinic and Strut Magnet in San Francisco, that people's adherence tends to drop off before they eventually stop PrEP. So we're not just measuring adherence, we're also capturing people at a critical moment when perhaps their PrEP motivation is waning and they're likely to discontinue in the future. Okay. Now, going to get into implementation science. So how many folks here are familiar with the behavior change wheel framework? It's like the majority, but not all. So behavior change wheel is an intervention design framework. When they designed this, they really wanted to be a synthesis of the frameworks that were out there. So they did this because they felt none were comprehensive. Susan Mickey and colleagues, they couldn't be applied to every type of intervention. Few were coherent conceptually, and few linked to a general theory of behavior change. The advantages of BCW and other frameworks have sort of caught up over time, but I still like it for a variety of reasons. It incorporates common features of prior frameworks. It links to behavior change theory. It helps you identify concrete and distinct intervention functions, which are based on a meta-analysis. So if you say motivation, this type of motivation is a problem for my behavior, there is a recommended type of intervention that you can use to try to affect that. Something like feedback on the behavior, which I'm going to talk about with drug level feedback, would be one of the suggested interventions. So it encourages consideration of the full range of barriers and intervention options. COM-B, not sure why that was bad, but COM-B is the center of the behavior change wheel. It's a pretty simple behavioral change theory. It posits that all behaviors are influenced by capability or really skills and knowledge. Motivation is really central. You can't just know that you need to do something. I know I should not eat this pastry, but the motivation is high to eat the pastry or low to not eat the pastry. An opportunity is really getting at structural factors. And COM-B in the behavior change wheel really focuses on individual level behaviors. So it posits that key behaviors are made up of the actions of individuals. It's a very individual focused framework. That is a downside, but it also is a strength depending on your behavior. Some behaviors really work best with this framework, and I find it's perfect for medication adherence. So that's why I use it. They're further divided into psychological and physical capability, reflective and automatic motivation. Reflective is sort of your own reflections on your motivation to have a behavior, whereas automatic are things like habit or automatic, using the same word again, things like habit formation, routine setting. Opportunity is physical and social opportunity. So the structural context is considered to be both the physical environment and the social environment, and all of these things interact. So how might we use a point of care drug level test to improve adherence? There are a variety of implementation strategies or co-interventions you can use, things like text messaging, peer support, motivational interviewing is one that works really well with COM-B, which has motivation at its center. And that's what I focus on in a lot of my work. But you can also use the point of care test to do other things like target follow-up interventions. I'm going to talk about one where we're using the urine test to either route people towards an adherence intervention if their adherence is low, or towards resistance testing if their adherence is high. That's a real feature of HIV drug resistance, that you have to be taking the drug to develop resistance. Okay, and I'm going to turn now to the focus of my K23 award, which focuses on adherence among young US men who have sex with men and other gay men. And I focused on this population specifically. I know this is a Global Health Institute, but this is where we really developed big intervention that has now been translated to a lot of contexts, including, so I'm going to talk about one of the global contexts next. The reason I focused on young MSM, 65% of incident HIV occurs among MSM in the US. Most is among those 25 to 34, and a substantial chunk is because 13 to 24. So I'm really focusing, most of my work focuses on those less than age 30. There is intersectionality between race and sexual preference in that Black MSM have a 1 in 2 probability, some people say 1 in 3, of developing HIV over their lifetime. So it's astoundingly high. And why adherence among this group? Well, we know it's low. There's high risk and also low adherence. In the US, young MSM PrEP demonstration studies, we found that only 55% had adequate adherence, and it lowered to 33% over time. And that's a lot lower than what we see in older adults. Taking a medication, and particularly if it's your first medication, is really a skill, and you have to learn those behaviors. So it's particularly hard for young people who also have a lot of competing things going on in their lives. Okay, so how would we address this problem using the behavior change wheel? The center of the behavior change wheel, again, is this COM-B theory, behavior change framework. And what I did is I did interviews with 20 folks who were at a PrEP visit at the Magnet Strut Clinic in Castro, and measured their urine and then interviewed them about what were the determinants, what were the things that impacted their adherence, the barriers and facilitators, and what did they think about using a urine test to try to motivate improved adherence. Quarter were not adherent to the sample. And some of the themes we identified, one key capability theme was pill taking despite contextual factors. A lot of folks talked about how they were often moving between apartments, staying with their parents, going to college, coming back. So really developing skills to be able to maintain your pill taking despite contextual factors. Some lost their housing, became homeless, or just like the weekend is very different from during the week, and maybe you're out partying, or so that there's like different changes to routines that occur over time. Motivation, one real facilitator was social identity as a PrEP user. The counter of that, I put this under opportunity, but is PrEP stigma and being seen as using a party drug, and being shamed by others. Also, PrEP being seen by others as a marker of infidelity. So if you're in a stable relationship, the use of PrEP can cause your partner to question you. So those are really key themes. And the substance use and mental health were really central to people's needs. So after that, we also interviewed providers, which I'm not going to cover, but working with an expert in motivation interviewing, we developed this intervention, and it has several intervention functions. One of the subsequent steps in the behavior change wheel, after you identify your barriers, you pick broad categories of how your intervention is going to work. And an intervention focused on motivation really depends on things like persuasion and enablement. We also do some training, teaching people about how PrEP works and the importance of adherence. The first step of the intervention is we actually measure their adherence, and we do it with them. They get to see the test. That gives a little bit of tangibility to the intervention. Teach them about the level of protection based on adherence, and really gauge their motivation to continue taking PrEP versus using another strategy, with a real preference that people remain on PrEP, because folks are generally pretty bad at assessing their own risk of HIV. So the next step is to do some motivational interviewing tools, things like the readiness ruler, elicit supporting factors, have them tell us what really motivates their desire to use PrEP. And then the last step is action planning, enablement, sort of figure out what are we going to change, what are we going to maintain, identifying specific strategy. Sometimes it can be as simple as you're going to put your pill bottle next to your toothbrush. I have a classic one. Or one of my patients who is moving housing a lot keeps his PrEP in his coin pocket of his jeans to help him find it. Agreed, and then you agree on a follow-up time. That's really a key part of action planning. This is sort of, I like my diagrams. I'm showing you the full diagram here, and shows you how everything intersects. So these are just some motivational interviewing tools. Given our preliminary data about the barriers to adherence. The first session is focused kind of getting to know the participant and understand what impacts their adherence and giving them drug level feedback using things like visuals. The second session focuses on what we call the menu of options, where they can focus on a particular theme. And the three themes we picked were substance use, mental health, and negotiating PrEP use within partnerships. I mentioned how, like, PrEP as a marker of infidelity, how do you talk to your partner about your PrEP use? How do you and your partner, potentially, ideally, you and your partner would both use PrEP together and kind of motivate each other. So we assessed it in a pilot RCT. This study was supposed to be a clinic-based study, but due to COVID-19, we switched to a mHealth study, and it actually ended up working pretty well for us. Recruited people from social networking apps in this field. That's usually a hint that we use Grindr to recruit people, and that's what we did, which is a really great way to reach people who are at risk of HIV. We're using PrEP, and a really great partner that allows you to advertise. Now, unfortunately, at really increasing costs. But we did 2 sessions via Zoom. As I mentioned, we have 2-to-1 randomization. So we're really focused on the implementation teams and to understand how the intervention was working. So 40 did the intervention, 20 to the control. The primary outcome was hair tenofovir levels. We don't like to use the urine test as an outcome because we are we're not directly incentivizing people to have high adherence of the urine test, but there can be things such as white coat adherence, like how you maybe your flossing improves before you see the dentist. We didn't want to use urine as the outcome, so we used a long-term metric of adherence, and that really allows us to show the day-to-day behavior averaged over 6 to 8 weeks. So it's a really nice outcome for that. We also looked at acceptability, feasibility, and I'll meant to talk a little bit about how we assessed intervention fidelity, which was a new thing for me. So what we found is that our participants had a median age of 26. They were a little older than we would have liked. It was really hard to recruit the youngest folks. 30% were Hispanic, 26% were Black. 93% reported the intervention was at least somewhat acceptable. 7% were neutral. We actually video recorded the Zoom sessions and had an expert in motivational interviewing read them for fidelity. Her name's Jennifer Manuel, based at the VA. She's really the world expert. There's actually a scale called the Mighty, which we're not getting into, but she thought that the technical fidelity of the motivational interviewing was 87% good or higher, and 100% had relational intervention fidelity. So that's really like, how good are you at really getting to know the participant and understand their issues and be empathetic, and all the things that we should ideally always do as providers, but somehow I think maybe 100% would not be a score for all of us. So what we found is that, so we measured adherence at baseline and follow-up, small sample. We wanted to make sure we didn't have imbalance in the randomization, and that did sort of occur. The intervention group had a little bit worse adherence at baseline. You can see the orange line, that the control group had the pattern that we typically see in PrEP adherence, particularly in young people. Adherence gets worse over time, and the intervention group actually increased their adherence, statistically significant, and it was equivalent to a 1 to 2 dose a week increase in pill taking. Among those who were less than 4 doses a week, 6 of 10 increased above 4 in the intervention group, and 0 of 5 in the control. And this was a quote. I think it makes most sense for providers to give a test like that. I do think there's a benefit for individual use, for your own kind of peace of mind, for your own benefit. And in this study, they were actually self-administering their urine test and meeting with the counselor right after. So I'm going to leave PrEP now and talk a little bit about subsequent studies that we've done in a global health context. There is a PrEP study that Dr. Gandhi led in Kenya with a very similar approach, somewhat based on my work with young women. And it was also effective, slightly different context, but we've sort of shown in 2 contexts now, in young MSM and young women in Kenya, that this approach works. The question is, could we use this urine test for treatment? A lot of international partners, including WHO, is most interested in this in the treatment context. I mentioned viral loads are really scarce. They're quite expensive, so they're not done that frequently. What if we had a very cheap adherence test? This urine test is projected to cost about $1 a test for someone like PEPFAR, probably lower. In the United States, probably would be more, these are really cheap to produce. These are like COVID tests or pregnancy tests. They work very similar. You collect your urine in a cup, and you use a dropper to put 3 drops of urine onto the urine test. So the COVID test is more complex in a sense because you have to dilute, but this is pretty easy to do. What if we had both the viral load and the adherence test? If both the viral load is undetectable or suppressed and the adherence is high, that's awesome. We can give the person positive reinforcement. And that does seem to make a difference. Even folks who are adherent really like that positive reinforcement. It does seem to help them. Folks who have HIV viremia and low adherence, that is adherence challenge. We need to figure out what's going on, do things like motivational interviewing to identify a barrier, do action planning, and try to help people address the circumstances in their life that are making it hard to take medications. So folks who have high adherence and HIV viremia, that's most concerning for resistance. In that context, we would ideally perform a genotype. That's how we look for resistance to HIV. Unfortunately, genotypes are not currently done almost anywhere globally because they're so expensive. But what if we had a test that could help us target that? Maybe the cost effectiveness would be higher if we only did it in the people who actually needed it. And it's important to know the vast majority of high viral loads is non-adherence, not resistance. Resistance has become relatively rare in the more modern HIV measurements. So the last group I think is kind of interesting from a counseling perspective. They're the folks who have suppressed HIV viral load but low adherence. Remember that the viral load is not a direct marker of adherence. The way your immune system works, the way the viral reservoir works, HIV treatment will really lower the amount of HIV in your body over time, but not eliminate it. And it takes time for the HIV virus to come up. So I think it's quite interesting to be able to find folks and do an adherence intervention before they run into trouble. And that has a lot of implications for preventing transmission, reducing inflammation, and getting to people when they need the help the most. We were approached by the CDC and the Ministry of Health of Namibia. Who were very interested in doing a study like this. And they're an interesting country because they have a generalized HIV epidemic with 13% prevalence, but very strong country level indicators. So they were sort of looking at how can we get to that 95%? We've reached the 90-90-90 goals, 90% diagnosed, 90% on treatment, 90% virologically suppressed. We want to do better. Like in the US and a lot of places, significant heterogeneity, more non-adherence, those are the red regions around the capital, Windhoek, and some issues over the border, which is a border region where there's a lot of migration. Given, and I mentioned this already, high barrier to resistance with the new first-line regimen, the world transitioned over to tenofovir, lamivudine, dolutegravir as the first-line regimen. Before that, we had regimens with a lot of resistance, but now resistance is quite uncommon. So adherence is the major issue. We really should have to do very few genotypes if we know what people's adherence is. So the study design was I originally wrote a very nice randomized study, and then the CDC blocked it, and then I wrote I think very nice stepped wedge study after they requested that instead, and then someone at the CDC blocked it. But Namibia was interesting, but unfortunately, that some of the conservatives at the CDC. But what we ended up doing is a pre-post study. We sampled several of the clinics where we would do the intervention, measured their what the virologic suppression over time would be folks who were failing first-line ART. We found that the current standard of care is to do something called enhanced adherence counseling, which is typically done monthly, certainly in Namibia and in most places. And folks come to pick up their ART, they meet with a counselor, and they have, it's not that different from motivational interviewing, but really kind of asking people about their barriers and trying to support them. But we're adding the urine test now, which makes adherence a lot more tangible, and we find it actually can be much more motivational to have that objective benchmark that patients are trying to meet. So the counterfactual was 40% virologic suppression in a population that had a high viral load. In the way that occurs with most studies, there was not a nice orderly progression through the behavior change wheel as what occurred in my prep study, because there are really a lot of pressures to do things quickly and stay within budget cycles. But we did do focus groups and some interviews with patients and key informants, and identified some salient issues. I'll show you. I made a quick slide on the next page to show that. And we modified the PrEP protocol to be relevant to HIV treatment and to be used in the context of EAC with the counselors that are currently doing this enhanced adherence counseling. So we call that EAC plus. We repeated the EAC plus out to month 9, and we had viral load testing out to a year. And the earliest they were willing to do a genotype was at month 9. So that was when we added an HIV genotype, which was not currently being done at all in the country. These are some about some of the barriers of facilitators. One thing that seemed like a real opportunity is have folks heard about U equals U? Relates that. So what U equals U stands for is undetectable equals untransmittable. And what that means is if your viral load is suppressed, it says U, but actually it's suppressed under 200 copies, you will not transmit your virus to others. So treatment is not just improving your own health, it's also helping your community, protecting your partners. It allows you to have sex without protection. So it's a big motivator for people. So we thought that could be a good one. And we weren't sure the counselors were actually talking about that, so that's something we added. Big opportunity barriers for stigma, much like the US, and facilitators for support for peers or partners. And the idea of seeing that was really emphasized is folks really distrust the blood tests because they would take a really long time to come back. They didn't feel as relevant. They're going off to South Africa to be done. People didn't totally believe the results or really understand the science at all. But even if you don't understand how a point of care immunoassay works, seeing the result is more tangible. It takes 3 minutes for the result. You watch it happen. So this is basically 1 month refills and getting this urine test counseling every month. Primary outcome is month 3 viral load. What we found is that 87% achieved virologic suppression at month 3, and that's compared to 40% in our counterfactual, which is, as you can imagine, highly significant. And we did have some loss to follow-up, which I'll show you. But if you look at the folks who made it to month 3, by month 12, 95% were virologically suppressed. So really, really outstanding. And because of that, only 5 individuals actually had to get a genotype at month 9. So we were wildly underpowered for that outcome, but that's a good thing. And we found no resistance in 4 out of 5. And in those individuals, their urines were positive about 50% of the time. And there was one individual who had very high level multi-class dolutegravir resistance, and 100% of their urines were positive. So this is a somewhat of an ugly slide that my colleague made, but it shows we had pretty high enrollment into the study. About 263 people approached, 211 were enrolled. 19 did not make it to month 3. 11 of them were lost to follow-up. Some transferred to non-study sites. 1 unfortunately passed away, not related to HIV in a car accident. And of those who made it to month 3, 92% were suppressed, with 195 and 95% by month 12. So this we published in the International Journal of Infectious Diseases, and led to request prior to the current administration to do a large randomized controlled trial, which was what PEPFAR and WHO wanted. And they said if it was effective, they would add to WHO guidelines after that. And we focused on South Africa unfortunate decision in the current context, but the country with the highest prevalence of HIV in the world, and also one that had actually added adherence testing to their guidelines in 2024, in part related to our work, but also some investigators in South Africa were doing plasma drug levels for things like dolutegravir. So there was a lot of interest in this strategy in the country. The idea was to do a randomized trial, and this has actually launched. One thing that one of the policies and under the current NIH regime was they will not allow new studies in South Africa, but if the clinical trial was ongoing, they got a lot of bad press because of the canceled clinical trials, including one of mine, which we use on the DSMB for. So they agreed to, after some backlash, they agreed to continue clinical trials that had already started. So we rushed very rapidly to start this clinical trial. You can see us pouring the concrete while we're visiting the site, not us. It's actually called the roving puma study. Pumas don't exist in Africa, so I have a photo of a leopard, but it stands for point of care urine monitoring assay, and I took that photo in South Africa. We have about 50 people enrolled, so I have no data yet from the study, but it's using a very similar approach to what we did in Namibia, only randomized to standard of care versus this EAC plus intervention. And some acknowledgements from my collaborators. Here.
Great, thank you so much, Matt. That was such a nice narrative of, I think, one thing that strikes me about the HIV field in general and implementation science is that probably we always do this in TV. We always compare ourselves, right, to HIV. And probably better than any other field, I think, in global health, HIV early adopted implementation science, I think, in a lot of ways, maybe because of the relationship between the disease and risk factors and barriers and facilitators and behavior kind of, writ large. But it's nice to see the narrative, even in your own career development, of integrating implementation science domestically, globally, bidirectionally, like learning from both contexts and doing it in a rigorous sort of way. So thank you for all of that discussion. I unfortunately cannot see the chat, but if you're putting questions in, please do, and I'm sure one of my colleagues can flag. But let's open it up for discussion. I'm kind of doing 15 minutes or so. Kanice, thank you.
Great talk. How do you think your findings can translate to long-acting injectables?
Yeah, the urine test would not be used in that context. That's a therapy where we are. It's like directly absorbed therapy because we have to administer it to the patient, so we know if they got it or not, and that's why they've been so transformational. Long-acting therapy even before the current administration was not going to be rolled out locally due to a variety of reasons, cost being one of them, and one of the drug companies, Janssen, did not want to license for delivery. So long-acting is a great solution, probably not a global solution yet, although I think it will be eventually. It has a lot of problems, though. There's a whole implementation science issues with how you administer a therapy on such a large scale, particularly one that's so costly and has cold chain issues. So I think implementation science really relates to long-acting therapy, and I wish more people were on it. Even in the US, though, the uptake of long-acting PrEP and treatment is quite low. About 1% of people are using long-acting PrEP instead of it being superior to oral therapy. A lot of people prefer oral therapy, including young people, because they don't want to go to the doctor's office every 2 months. That's changing now that we have an every 6-month therapy, and something I'm working on implementing in our clinic. But folks don't like to be in the doctor's office, and oral therapy, you can actually do self-testing. There's a lot of interesting studies with that. A lot of people are getting their medication through apps and actually never meeting a doctor in person, going to a local lab site like Quest or Lab4 and getting your labs there, or even doing like finger pricks for all their testing. So there's some advantages to oral. So I still think there is a need for adherence interventions.
Yeah, thank you. That was fantastic. I especially appreciate the attention to COM-B and like linking it with practical ways to like your research questions. It's really helpful. I did have a question about the EAC plus.
Yeah.
What's your sense of how much plus was the addition of the urine versus the addition of the urine plus, sort of something else? Like, I mean, were there other aspects of the training or just kind of like reinforced engagement in counseling, or was there anything else that might have influenced it in addition to adding the urine?
Yeah, I mean, these were people who worked in similar contexts and worked in clinics, generally not the same clinic that they had started in. But I don't think if we did a motivational interviewing fidelity scale of these counselors, I don't think it would be as high as my counselors were, just in terms of my interactions, and also just the things were very rushed with the implementation. So there actually was not a lot of attention to the counseling, I'll be honest. And I would have loved to have done qualitative research. The funding ended, and unfortunately there was not the richness of qualitative data available in that study that I would have liked. But my sense would be that it's mostly a urine test in that case. In the young MSM study, I can't tell you which part of it is, but in this study, I'm pretty sure it's the urine test that made the difference.
Matt, great talk. As I was listening to you, I was thinking about this comparison about TV. How does poorly tolerated medications disrupt the enhanced adherence counseling or any of the other techniques that you look at in HIV, which sadly our drugs are not well tolerated? So
yeah, I think about this a lot now because I got tuberculosis at work, so I'm taking 3-HP at the moment.
Oh yeah,
I find it very unpleasant. I don't feel good for 24 to 48 hours. Now we have once weekly therapy. So I've actually been looking a lot at the TB implementation science literature, including yes. I think it's hard. The thing about tenofovir is there are side effects. They do tend to get better over time. So that's one thing that we can really target in counseling. I know your first dose was hard. Let's try. Did you take it with food? Oh, you didn't. Let's try taking the next dose with food, and it gets better over time. That's such a helpful message for people to hear, and they don't always get. I think there are some things people can do in counseling and strategies you can give them to manage side effects, taking the food, doing it at night. So less of a focus of my work because our medications are pretty well tolerated, but I do think counseling helps for things like TB.
Yeah, there's large scale 3-HP rollout studies, as I'm sure you're aware, including still ongoing ones that are looking at the cascade and people dropping off treatment and discontinuing, and a lot of it is tolerability, frankly, and even before you get to the serious adverse effects, just people feel lousy taking a medicine that they don't have.
It's the INH, actually. I think this is the high dose of INH because I feel lousy right away.
Yeah.
Based on the pharmacokinetics, I think INH makes me feel bad.
Well, there is a new regimen that's going to be INH free. So
good.
What is INH?
Isoniazid. So it's a once weekly TB preventative therapy that you take when you have latent TB infection to prevent your TB becoming active.
But I guess the point is that a lot of the assumptions we have kind of get disrupted by poorly tolerated medicines, whether it's chemotherapy for cancer or anything like that. And the motivation has changed a little bit. You may want to be protecting your family from an airborne disease, and there's other factors that come in. It's a fascinating area to explore.
And we leverage that a little bit in HIV, as I mentioned with you equals you, although it's sexual transmission, not airborne transmission. That's totally fair. I do think counseling helps, and there are strategies that we all figure out as clinicians to help our patients take poorly tolerated meds. But sometimes the solution is better meds.
No,
which
it
is really the
it
case.
is
in
absolutely
HIV.
a solution. We have
Which
to
has really
make,
been the case in HIV over time. As the meds have got better, things have got easier.
and even adherence.
Yeah.
You know,
Long acting.
if we make better medicines that have a longer exposure arc,
Yeah.
then then you don't
Yeah,
need
so we have one every 6-month medication, which is
Yeah.
outstanding. We wish if we had two, it really would transform HIV, I think.
I also think like choice is an interesting paradigm for some of these. It gets back to the long-acting injectables question. It's preventive therapy generally. How would you want to receive something that you don't think you actually need because you don't experience symptoms and that sort of stuff? So with 3-HP, obviously, Adythia's work in that regard, and it's kind of asking people, trying to identify preferences is an interesting area for that to dovetail. But I see that Lisa had her hand creeping.
Yeah. I'm sort of thinking about this. I'm also in the TV world,
Cool.
so but yeah, really fascinating. And like Priya said, I think the adherence stuff in TV, I'm not like super dialed in. I'm a nurse, so more on the implementation end, which is why I like this. So the work around adherence. A couple of observations and a question. I mean, similar like with DOT. That is what you mentioned, the gold standard and what we use in TV. But I think some of the studies have found that the outcomes, it wasn't just observing the pills, it was the case management piece.
Yeah. That's interesting.
So
Makes sense
I
to me.
think I had the same question about the intervention of the urine testing. Was it truly the urine testing or the other things that were changed?
Maybe makes the counseling better, so you probably can't totally. I mean, you have to talk to the person.
Yeah.
You can't just give them the urine test. That's one thing we actually did find out is in interviewing people. People liked the idea of having the urine test, but they really wanted someone to kind of walk them through what it meant and what it meant for them. And that was another reason why we went this route of pairing the urine test with counseling. And I think you're right, probably DOT does have them. Also a lot of things like the text messaging interventions like WellTel, a lot of what my colleague did one in Chicago with young MSM for PrEP. And what people really said was they appreciated it, like, one, that someone cared, but also like the clinic processes are so terrible. It's really hard to call your clinic, really hard to talk to a human or schedule, and having like a way to bypass the crappy systems we've created to keep people to kind of reduce our workload, I think.
Yeah, and that kind of gets at my question is thinking of these things that are less individual choice driven, because you mentioned that like a lot of these models are based on the individual's choice, and just the data that struck me so much at the beginning was the Black men 1 in 2 probability of having HIV. Yeah. So the thought that like the power of other things.
Yeah, structural factors are really big,
which are harder to address.
Very hard.
Yeah. Just thinking, maybe alternate medications are in a way more of a systems intervention. So I'm just curious your thoughts on interventions that aren't as individual based.
Yeah.
It's a biggie, but
no, it's good. I mean, a lot of times we target our rollout specifically towards the populations that can benefit the most. That's a type of implementation strategy. I think about my colleagues at Emory who've done a really amazing job rolling out long-acting ART really at scale among adherence challenge populations, which tend to be more people of color because they have more structural factors interfering with their adherence. So yeah, I mean, I agree. And there's a lot of work and community engagement that has to occur. And I'd say our clinic is reasonably good at it, but we're also in a city where the Black population is shrinking and folks don't feel like they belong here. So there's a lot of important issues that have to be addressed, both at the community level. And there are frameworks that I like better for that, community empowerment theories. CFR, which I used to hate, I've sort of come around to, is good for like kind of looking at the intersection between the individual and more systems level factors. So there's some of the other frameworks that I use for issues that are, less individually based. But the economy does highlight the structural factors, unlike prior frameworks. One that we used a lot in adherence is the information, motivation, behavioral skills, which is focused all on your psychology and makes no acknowledgement that the structural factors are interfering. So yeah, we want to give individuals, the tools to deal with stigma and other things that are structural challenging.
Yeah. Pardon me? No, please go ahead.
No.
I insist.
I was thinking about your Puma study. How do you feel about incorporating hypertension, cardiovascular disease, and other, integrated care adherence issues. Did you do a sub-study in there, or hypertension management gaps?
Yeah, no, it's a great idea. I think the opportunities for supplements will be very low in our South Africa study. That we had to kind of be really creative with our program officers to be able to launch. We have a more observational study that was supposed to be in South Africa, but thanks to a really valiant program officer, is now going to be in Uganda. And so potentially there could be subsidies there. We have more opportunities for.
I mean, just generally, what do you think of that?
Yeah. Oh, yeah. Sorry, I'm thinking about the logistics of that rather than answering your question. Yeah, I think it's a great idea. I mean, the SEARCH study has shown that integrating community health with the HIV care makes a lot of sense, and the investments that the U.S., primarily the U.S., has made in developing these ART delivery systems really should have spillover effects in building primary care in areas that didn't have it before. So I think that's a great pathway to move forward in developing community health systems that focus on the full individual, not just their HIV. The problem will be the declining funding, lack of U.S. commitment to that type of work. But through the NIH, yeah, I think they're probably could be interesting.
Yeah, I think my kind of questions may be unfair and probably really actually a comment, but as more of a systems implementation scientist, I think maybe 3 themes that came out in this discussion that I would be really interesting to get your take on as avenues for thinking when you think of multi-level interventions, how you would, maybe this is what Lisa was talking about a little bit, like what would be better from a systems level to help some of those structural things.
Yeah.
I think your comment, for example, about integrated service delivery, the comment, I guess the comment you made about motivational interviewing being kind of like what your doctor's supposed to do anyway. And in my area of social and economic support, it's like the idea of wraparound services.
Yeah.
These are functions of a functioning health system.
Right.
And I often hate actually talking about these things in these types of seminars where we're trying to integrate people who are in different disciplines to be like, come and do implementation science, because they're like, this is so stupid. Like, duh.
It's all like primary care, wraparound services.
Of course, if you had a doctor who cared about you, you would come back to the doctor's office, right? So how do you kind of address those caricatures sometimes of implementation science as like the duh stuff? And 2, could you imagine a study, or do you have a wish list for a study that would incorporate more systems level refinements that would support some of the work that you're doing now?
Yeah. I mean, I think you bring up a good point about really that tension of doing research that is valid and true and impactful. I think about the work Michael Mugavero, UAB did, where if your patient missed an HIV visit, you had a staff member who the person knew call the patient and ask them what's up and recommend they schedule a new appointment. That turned out to be a very impactful strategy.
Yeah.
But I don't really think it's done because of the dysfunction of the health system, lack of funding, doing more with less that sort of is required in the US. It probably works in other places, but in terms of how do you do interventions in systems, multi-level interventions in a dysfunctioning system, to be part of your question, I think there are interesting things you can do around the edges. Like housing is so key for so many of the issues we address in HIV, and there have been programs that have incorporated housing with care services, such like what occurred in COVID-19. A lot of people got housed for the first time in their lives connected to care, but there's probably not a lot of will for that right now. I think a little bit about things like pharmacies. We talked a lot about the racial disparities. A lot of work has been done starting to be done to make PrEP available in pharmacies, and I think we all love a future where people can get long-acting PrEP in pharmacies. People are doing work on that. There was a lot of challenging insurance and regulatory things that interfere with it, but I like that idea because they're in people's communities. They tend to be people from the community that work at pharmacies. There are much more of them, and there are healthcare sites. So I think that's one example. Or or you think about like barbershop hypertension study, meeting people where they're at, doing things in the community.
Yeah.
So
it's great. Yeah, I think my kind of only comment, and then we can close here about the studies, is that I take the feedback, and then I look at the New England Journal papers, like the trials that you started your talk with. We do the same thing in our TB sphere. 2010, TB 3HP, 2011, right? And then you look at current day coverage of that intervention, and it's abysmally low. Yeah. And so when I'm faced with
it was very hard.
This is a DUH study.
I called 5 or 6 pharmacies. I messaged the TB controller to ask her if I could get it through DPH. And eventually, the only way I found it was at a random community pharmacy next to UCSF Health, just kind of randomly. But Walgreens didn't have it. Kaiser doesn't have it. CVS doesn't have it. None of these large pharmacies.
Someone else can correct me, but ricapentine wasn't included on the Medi-Cal formulary until maybe 2 or 3 years ago. So just to say that it is a DUH study, but somehow the world is not able to implement these things without that kind of evidence. So it's really critically important. Anyway, more food for thought, I'm sure. But here's a highlight of upcoming events in the December and January. The open house tomorrow. Yep. Our Global Partner Spotlight on December 18th. And another one January 15th, which are really exciting to have partners from around the world join in our events and really kind of provide essential context for the discussions that we have related to December, HIV/AIDS, and ongoing through the year. So Matt, thank you so much for your time and sharing that spectrum of work. I invite people to email Matt if you're interested in learning more, curious for our students and trainees and getting involved in HIV-related research domestically or globally. Just curious about frameworks, or to please take one of his courses, his Implementation Science Training Program course on designing individual level behavior change strategies. So appreciate your time. And thanks to all who joined.
That's great.
Thank you.